Hello students, welcome to ePathshala. I am Sabah Khan and I will teach you today about drug concentration and therapeutic response. In drug concentration and therapeutic response, we will be discussing about dose concentration response relationship, type of dose and response relation, in which we will discuss about potency, efficacy, selectivity and affinity. Then we will be talking about therapeutic window. Then finally we will discuss about the relationship between drug concentration and pharmacological effect in the whole animal and human. Next we will be discussing about pharmacodynamic models and onset and duration of action. To produce therapeutic effect or minor, major, serious and severe toxic effect, drugs interact with receptors, ion channels, membrane carriers or enzymes in the body. This is the pharmacodynamic phase of drug action. The drug in the tissues where drug receptor interactions usually occur is in equilibrium with the unbound drug in the plasma. Drugs interact in a structurally specific way with these protein receptors. Activation of receptors in response to drug binding leads to activation of a second messenger system, resulting in a biochemical or physiological response. For example, changes in intracellular calcium concentration lead to muscle contraction or relaxation. There are different types of receptor families. Primarily, four main type of families we can talk about are ligand gated ion channels, G protein coupled receptors or GPCR, enzyme linked receptors and intracellular receptors. The most common receptors that are targets for drugs are the G protein coupled receptors. GPCR are transmembrane receptors linked to guanosine triphosphate binding proteins or G proteins which activate second messenger systems. These second messenger systems include adenylyl cyclase, which are activated for example by beta adrenoreceptors, or inositol triphosphate pathway. It is also a second messenger system which is activated by alpha adrenoreceptors. Now we will be discussing about the terms like agonist, antagonist, partial agonist, etc. What are agonists? A drug which binds to a receptor having affinity, intrinsic activity and produces a maximum effect is called a full agonist. A drug which binds to receptor produces intermediate efficacy and produces submaximal response is called as partial agonist. Partial agonists produce a therapeutic effect if no agonist is present, but can act as antagonist in the presence of a full agonist. For example, pindolol, that is beta blocking agent, is a partial agonist. It produces a smaller decrease in heart rate than that produced by pure antagonists such as propranolol. Drugs which bind to receptor but do not have intrinsic activity and have zero efficacy are called antagonists. An antagonist produces its effect by counteracting the access of natural transmitter agonist to the same receptor such as atropine, which is antagonist, versus acetylcholine, which is an agonist on muscarinic receptors. An inverse agonist is a molecule that binds to the same site as an agonist but produces an opposite response or negative efficacy. Currently, there are several drugs such as haloperidol, chlorpromazine that have inverse agonist activity at dopamine and serotonin receptors are used clinically. Antagonist comprises of mainly two subcategories, competitive and non-competitive. What is competitive antagonist and what are non-competitive antagonists? Competitive antagonists involve competition between antagonist and agonist and bind reversibly to the same receptor site. Antagonist inhibitory effects for the same receptor can be overcome by addition of a higher concentration of agonist. In the presence of competitive antagonists, higher agonist concentration are needed to produce the same effect as in absence of antagonist. So, the presence of a competitive antagonist causes a rightward shift of the dose response curve of the agonist. The majority of clinically used drugs act as receptor antagonists are reversible competitive antagonists. Agonists like isoproterenol and the antagonist propranolol are good examples of competitive antagonism. Now there is non-competitive antagonism. What are non-competitive antagonists? They bind irreversibly by covalent bonds for the same receptor site as the agonist or bind to a different site of same receptor, which reduces the binding capability of the agonist by an allosteric mechanism. So, due to irreversible strong binding of receptor site, the effect of a non-competitive antagonist cannot be reversed even at higher concentration of agonist as in case of competitive antagonism. So, because of the loss of mass action does not apply here. The primary effect of non-competitive antagonist causes rightward shift of dose response curve and reduction in the maximal effect produced by agonist. There are three other types of drug antagonism like physiologic antagonism, which involves when one drug antagonizes the action of other drug by acting on different receptors and mechanisms. For example, acetylcholine vasodilation and norepinephrine vasoconstriction. Now there is chemical antagonism. Chemical antagonism occurs when one drug antagonizes another drug by chemical interaction and leads to a reduced response. For example, interaction of positively charged drug protamine sulfate which neutralizes the effect of negatively charged drug heparin. Next is pharmacokinetic antagonism. It occurs when one drug suppresses or accelerates the effect of a second drug by change in pharmacokinetic of drug, such as its increase or decrease in absorption, distribution, metabolism and elimination. For example, phenobarbital increases the metabolic degradation of anticoagulant warfarin. Selectivity in drug action is associated to the structural specificity of drug binding to receptors. For example, propranolol binds equally well to beta 1 and beta 2 adrenergic receptor, whereas metoprolol and atenolol bind selectively antagonist at beta 1 adrenergic receptor. Next example is salbutamol, which is a selective beta 2 adrenergic receptor agonist, and in this case additional selectivity is achieved by inhaling the drug directly to its site of action in the lungs. Next we will be discussing about dose concentration response relationship. So, regardless of how a drug effect occurs through binding or chemical interaction, the concentration of the drug at the site of action controls the effect. However, the relationship between response and concentration may be complex and is often non-linear. So, when discussing the drug action at the tissue level, we refer to drug concentration, while when referring to drug action in the whole animal person, we refer to the drug dose. When a drug is administered in animal or human, the relationship between drug dose regardless of route used and the drug concentration at the cellular level is even more complex. The concept of the dose response curve or concentration response curve is one of the most important parts of the pharmacology. A dose response curve describes the relationship between an effect of a drug and the amount of drug given. Dose response curves are essential to understand the drug's safe and hazardous level so that the therapeutic index can be determined and dosing guidelines can be created. Dose response curves are charted on XY axis with the drug dosage measured usually in milligrams, micrograms or grams per kilograms of body weight for oral exposure or milligrams per cubic meter of ambient air for inhalation exposures, typically on the x-axis, and the response to the medication typically on y-axis. When considering responses at the tissue level, the quantity of drug is expressed as its concentration, usually expressed as a molar concentration, although where the molecular weight is unknown, we would express the concentration as microgram, nanogram or milligram as appropriate. As the relationship between response and increasing dose or concentration is best described by a logarithmic plot, dose response curve or concentration response curve are graphed with the dose or concentration on a logarithmic scale on x-axis as opposed to a linear scale. In such cases, the curve is typically sigmoidal with the steepest portion in the middle. So, when evaluating a dose response curve or concentration response curve, one of the main characteristics is a graded relationship between the response and the dose or concentration. This means that as the amount of drug given is increased, so is the response to the drug. So, there are three phases of a dose response curve or concentration response curve. First, the curve is a flat as the quantity of drug is given is not sufficiently great to initiate a response. The first point along the graph where a response above 0 or above the control response is reached is usually referred to as a threshold dose. In the second phase, the curve steadily rises. With each increase in the drug dose, there is also an increase in response. At higher doses, undesired side effects appear and grow stronger as the dose increases. The more potent a particular substance, the lower the concentration or dose required to produce an effect. Finally, the curve plateaus at the top, indicating that any further increase in drug dose will not produce any further increased response to the drug, which is also called as emax. Next is types of dose and response relationship. A fixed dose administered to a range of individuals will produce a range of concentration measurements due to pharmacokinetic variability among individuals. So, these concentrations will also change over time. In addition to this, a range of responses can be determined, both therapeutic response and toxic effect. It is therefore common to consider concentration effect relationships rather than dose response relationship. The concentration response relationships are of two types, graded and quantal. A graded concentration response curve are plotted for responses such as contraction of muscle, which is determined on a continuous scale. Graded response curve relate the size of the dose to the intensity of response and hence used in characterizing the actions of drugs. Therefore, the percentage of the group responding to increasing dose is plotted. A sigmoidal response or graded response curve is constructed. On the other hand, when a drug is administered to the whole animal, certain types of responses may be all or none. For example, before immunoassays were developed, the potency of insulin was determined by administration to mice where it caused convulsions due to large reduction in the blood glucose. In this case, convulsions either occurred or did not occur. This is termed as a quantal response, and the relationship is defined as the percentage of animals showing the response and the dose of the drug. The doses required to produce a specified quantal effect in an individual population or experimental animals are log normally distributed. The cumulative frequency distribution of such responses plotted against the log dose produce a Gaussian curve. Next, we will discuss about the potency. Potency refers to the amount of drug required to produce a certain response. A drug which produces a certain effect at 5 mg dosage is 10 times more potent than a drug which produces the same effect at 50 mg dosage. In other words, potency is defined as the dose ED50 or concentration EC50 of a drug required to produce 50% of the drug's maximum effect. This potency depends on both the efficiency with which drug receptor interaction is coupled to response and affinity of a drug for its receptor. Potency is inversely related to the dose of drug required to produce a therapeutic effect. Potency of drug is important in selecting dose of a drug. Graded dose response curve provide information on the potency of drugs that is different from information derived from quantile dose response curve. Next is efficacy. Efficacy or intrinsic activity is the ability of the drug to produce a maximal response when it binds to the receptor. Conformational changes in receptors because of drug occupancy activate physiological events and biochemical that characterize the drug response. In some tissues, agonists demonstrating high efficacy even when only a small portion of the receptor is occupied. Difference in drug efficacy can be evaluated by looking at maximal response produced by different drugs. Agonists can also differ in terms of their efficacies. In the figure shown on screen, 4 agonists that differ in their relative efficacy but have same potency are being described. Drug A is the most efficacious and drug D the least efficacious. Drug B and C that bind to a receptor but produce less than maximal response are called partial agonists. In figure 4 shown on the screen, drug X has greater efficacy per dosing equivalent and is thus more potent than drug Y or Z. Drug X and Z have equal efficacy indicated by their maximal response or ceiling effect. Drug Y is more potent than drug Z but its maximal efficacy is lower. There are many examples of potency and efficacy. For example, aspirin is less potent as well as less efficacious than morphine. Pethidine is less potent analgesic than morphine but equally efficacious. Diazepam is more potent but less efficacious than pentobarbital. Similarly, furosemide is less potent but more efficacious than metalazone. Depending on the type of drug, both higher efficacy or lower efficacy could be clinically advantageous. Now we will be discussing about equilibrium dissociation constant. The concentration of a ligand that occupies half of a particular receptor population is called dissociation constant. Kd is determined experimentally and is a measure of the affinity of a drug for a receptor. Drugs with high Kd or low affinity dissociate rapidly from the receptors. Conversely, drugs with a low Kd or high affinity dissociate slowly from receptors. High affinity binding occurs at low drug concentration. Conversely, low affinity binding occurs at high drug concentration. If a ligand has affinity, it does not necessarily mean that it will produce a response. For example, an antagonist that displays high affinity does not produce a response in its own right. Next, we will be discussing about drug selectivity and affinity. Selectivity refers to drug's ability to preferentially produce a particular effect and is related to the structural specificity of drug binding to receptors. There are certain examples of drug selectivity. For example, atropine, a muscarinic receptor, salbutamol, beta-2 adrenoreceptor, and cimetidine, H2 receptor antagonist. By contrast, non-selective drugs resulting in drug effects through several mechanisms of action. For example, chlorpromazine causes blockade of D2 dopamine receptor, alpha-adrenergic receptor and muscarinic receptor. Lack of receptor selectivity is one cause of adverse effect. For example, chlorpromazine may cause a dry mouth by blocking muscarinic receptor in the doses used to treat schizophrenia. Next is affinity. Affinity of a drug for a receptor describes how avidly the drug binds to the receptor. The chemical forces in drug-receptor interactions include electrostatic forces, van der Waals forces, and the forces associated with hydrogen bonds and hydrophobic molecules. Variation in the strength of these forces and therefore the thermal energy in the system determines the degree of association and dissociation of the drug and the receptor. Covalent binding of drug to receptor, exemplified by fluoroquinolones acting on bacteria, leads to formation of an irreversible link. Next is therapeutic window. The optimal design of a therapeutic dosage regimen is generally established on the basis of systemic exposure-response relationship, with the aim of achieving a desired safety-efficacy balance for a given drug. Therapeutic window, which is typically considered as the therapeutic range of drug's plasma concentration associated with safe, effective treatment, is an important parameter in efforts to attain this equilibrium. Drugs with a good therapeutic window are effective in a range of doses that produces therapeutic response without causing any significant toxic side effect in patients. The therapeutic window is the ratio of the maximum safe concentration, that is MSC, to the minimum effective concentration, that is MEC. The concentration of drug should always lie in between MSC and MEC in order to provide risk-free therapeutic success. If any drug exceeds the MSC, then it will surely produce adverse effects. If the drug is unable to achieve the MEC, this will result in therapeutic failure. The therapeutic window is also termed as the safety window and can be quantified by the therapeutic index. What is therapeutic index? It describes a relationship between the doses of a drug that causes lethal or toxic effects with the doses that cause therapeutic effect. It is also referred to as therapeutic ratio. Therapeutic index is measured by dividing lethal dose by effective dose 50. Lethal dose 50 is the dose producing lethal effect in 50% of the population. LD values almost always refer to animal studies since lethal doses in humans are rarely known. Toxic dose. Toxic dose 50 is the dose producing a toxic effect in 50% of the population. ED50. ED50, quantity of a drug that can produce desired therapeutic effect in 50% of the population. Such type of studies are usually conducted in animal models or patients. It is to be notified that drug concentration producing 50% of maximum effect are used for in vitro studies only. Drugs having a wider therapeutic window are safer in comparison to those having lower therapeutic window, because minor modification in the dose of such drugs will not produce toxic effects. Some drugs, for example digoxin, phenytoin, lithium, have a narrow therapeutic window, resulting frequently in toxicity in therapeutic doses. Increasing the dose of a drug with a narrow therapeutic window increases the probability of toxicity. A drug having therapeutic index of 2 or less than 2 would be relatively narrow therapeutic window. For some drugs such as cancer chemotherapeutic agents, the therapeutic effect cannot be achieved without toxicity because the doses are required, for example, to kill cancer cells, may also affect some other rapidly multiplying cells such as those in the skin, bone marrow and gastrointestinal tract. In this slide, therapeutic window of selected drugs where concentration above the therapeutic range will cause toxicity is shown. So when drug concentration is not a good indicator of response, then what happens? Drugs used at concentration which gives a maximal response, hit and run drugs. Some drugs act irreversibly, example classical MAO inhibitors. Termination of effects rely on synthesis of new MAO so that there is no obvious relationship between drug concentration and effect. Delayed distribution. The site of drug action is at a site to which the drug is slowly distributed. For example, in case of digoxin, the effect increases as the drug concentration falls due to redistribution. Drug concentration soon after a dose cause a smaller effect than the same concentration caused later when distribution to the site of action has occurred. Now, there are examples when the wrong effect is measured. For example, after the first dose, the effect of warfarin on prothrombin time increases as the warfarin concentration decreases. The rate of onset of effect is measured by the rate of decay of existing clotting factors. However, the direct effect of warfarin is on the rate of clotting factor synthesis. If this is determined directly, warfarin concentration correlates well with the response. Now there is acute tolerance or tachyphylaxis. Examples are amphetamines or cocaine. Drug concentration soon after a single dose cause a greater effect than the same concentration caused at a later time. Next is PD modeling or pharmacodynamic modeling. What are pharmacodynamic models? A pharmacodynamic model is one that describes the relationship between drug concentration at the site of action and the effect. PD model or pharmacodynamic model use data derived from plasma drug concentration versus time profile and from the time course of pharmacological effect to predict the pharmacodynamic of drug. Now there are various direct and indirect pharmacodynamic modeling. First pharmacodynamic model involves simple and direct effect model. In this, effect of drug is direct, fast mechanism of action is there, rapid equilibrium exists between the site of action and sampling by a fluid. PD parameters are time invariant. Then there is linear model in which drug effect is directly proportional to drug concentration. Pharmacodynamically, it can be explained by equation in which effect of drug is equal to drug concentration multiplied by slope obtained from E versus C graph, where E is effect of drug and C is drug concentration. The equation is modified in case of baseline effect when the drug is absent, as given in the following slide. Another pharmacodynamic model is log linear model. In this, when the effect of a drug is measured over a large range, the relationship between concentration and the effect is not linear and may be curvilinear and log transformation is needed. Hence, the model are only valid within certain range of drugs concentration. The drug response has to be within the range of 20 to 80% of the maximum effect. In the graphical representation of this model, that is log linear model, it can be understood that it expands the initial part of the curve where response is slowly making progression before it accelerates. Then it contracts in the later part of the curve where a large change in concentration produces a slight change in response, and in middle part relationship is linear. What are the advantages of this PD model? Unlike linear model, it is applicable over large concentration range. The limitation of log linear pharmacodynamic model include pharmacological effect that cannot be estimated when the concentration is zero because of the logarithmic function, and maximum effect also cannot be predicted. For example, this model has been successfully used in predicting the pharmacological activities of beta blocker and anticoagulants. Next is emax concentration effect model. In this, it is seen that concentration of the test drug are increased further. The increase in response is very small as the effect reaches emax. So, E naught, the maximum possible effect, and the drug concentration producing half maximal effect. This model mimics the hyperbolic shape of pharmacological response versus drug concentration curve. After maximum response, that is Emax, has reached, no further increase in pharmacological response is seen or increasing in concentration of the drug. So, EC50 is useful for determining drug concentration that lies within the therapeutic range. What is the advantage of Emax concentration effect model is that maximum pharmacological response can be found out. EC50 can be calculated, that is concentration needed to produce half maximum response can be calculated. There are also limitations of this model, which include in case of highly potent drugs, it is not possible to find the maximum effect because test organisms die long before the maximum effect is attained. Another limitation is the method can be time consuming if maximum effect is obtained at a very high concentration. For example, bronchodilator activity of theophylline is studied with the use of emax concentration effect model. Another pharmacodynamic model is sigmoidal emax model. It is a further extension of emax model. It contains an additional parameter called gamma, which is the slope factor of curve to describe the steepness of the concentration effect curve. A steep slope with gamma greater than 1 implies that a small change in concentration will produce a large change in effect. At the extreme, it is sometimes reported as all or none response. A shallow slope indicates that a large change in concentration will be required to achieve a change in effect. This is often referred to as flat dose response. Now the last is onset and duration of action. A rapid equilibration between drug plasma concentration and its site of action coupled to a rapid onset and offset of effect will produce an effect time profile that mimic the drug concentration time profile. However, for many drugs there is a delay in such equilibration. The factor which influences duration of drug action are amount of drug or dose size and the rate of removal of drug from site of action. Alternatively, the pharmacological response may depend on a time-dependent induction or inhibition of a biochemical or receptor process. In these cases, the maximum effect does not occur at the time of maximum concentration but lags behind. For example, if an antibiotic is given by IV bolus injection to treat a deep-seated tissue infection, the maximum drug concentration will occur at the time of the injection. However, it still has to distribute to the tissues and then into the organism to exert its effect on cell wall or protein synthesis. The onset and duration of the response to warfarin depends both on pharmacokinetic of warfarin itself and of the clotting factors. These delays lead to a lag between peak blood concentration and the peak effect. To conclude, in this module we have learned about dose-response relationship or concentration effect relationship, which holds great significance in pharmacology. We have learned about agonist, antagonist, their mechanisms, how they bind to receptor and exert their effect. Then we have learnt about different types of dose response relationships like potency, affinity, efficacy, selectivity. Then we have learned how to measure the graded and quantile responses. In the end, we have learnt about different pharmacodynamic models and their advantages and disadvantages. We have also learned about the therapeutic window of a drug, which is calculated on the basis of therapeutic index.